So we're going to talk about knee function, and knee function is kind of fun to look at, especially given the variations in the way we're built. I mean, go hang out at the mall and look at people walk by. We come in every shape and every size, and we see people that look like they just got off a horse, and we see people that look like they can barely advance their legs because their knees keep hitting each other. But that kind of comes back to looking at alignment. And alignment really looks at the mechanical and the anatomical axes in the femur. Now, the anatomic axis of the femur is oblique. It runs the length. That's my dotted line. And it is directed inferior medially at the distal end. So it moves towards the midline at the distal end, while the mechanical axis runs from the head of the femur through the knee joint and runs with the anatomic axis of the tibia, which is just about vertical. So in a normal, if there is such a thing, individual, the anatomic and the mechanical axis form an angle medially or in a valgus direction at the knee joint of between 5 and 10 degrees. Now it averages about 3 degrees from the vertical given the width of the hip. And if I look at the medial-tibial-femoral angle, if it's greater than 15 degrees, then we have what we like to call genu valgum. Genu valgum is that knock-kneed looking type position. If the tibial-femoral angle is less than 0, so the anatomical axis and the mechanical axis tend to line up with each other, we call that genu varum. And that would be that individual that looks like they're a little bit bow-legged. Their knees are moving away from each other. So my question then is, when are we born with what we have in terms of a genu valgum or a genu varum position, or does it change? And the answer is really a little bit of both. So we have this genetic predisposition to having, to normal alignment. You can blame your parents on that. But if we have a knee position that's in a varum or a valgum direction, excessively varum or excessively valgum position, what tends to occur is we may end up with increased tensile or compressive forces through the medial or lateral compartment, depending on if we're in a valgum position or a varus position. And over time, that compartment may begin to break down. And when it begins to break down, guess what? We end up with a greater valgus position or a greater varus position. I worked with a therapist a number of years ago, and he played college football in the 60s and had beaten his knees up pretty significantly, and he had probably a 15 degree varus position in both knees. He'd stand with his feet together, and it looked like an O. His legs almost looked like they were, they'd created an O. And so he was in a lot of pain, and eventually he had a knee replacement. And when he got his knee replacement, they realigned his mechanical and his anatomical axis. And so it brought his femur back in line. And when he had his first knee done, he had a straight leg on one side and still was in that varus position on the other side. So I always teased him, and I said, hey, you went from having, from looking like a Cheerio, now you look like a D. And then eventually, about 11 months later, he got his other knee done, and his legs were straight. And I looked at him, I laughed, I said, man, you're 2 inches taller. So those alignments will have an impact on what happens when we break down and what can occur. So that's the mechanical and the anatomic axis of the femur. We also kind of have an axis at the tibial-femoral joint. And the axis for flexion extension at the tibial-femoral joint passes horizontally. and it passes through at the femoral condyles at kind of a right angle. But we'll notice that, again, remember, our lateral femoral condyle is a little bit smaller than our medial femoral condyle. And so when I put a line through the axis, it doesn't line up perfectly perpendicular. It's slightly offset. And consequently, and you can do this, just go ahead and sit or stand and bend your knee. And when you bend your knee, you'll notice that your foot, your heel, tends to move slightly towards the midline. And that's due to that obliquity of the axis. And so as you straighten it, it moves slightly laterally. Now, we're not talking transverse plane motion. We're talking sagittal plane motion. Okay, so it's, again, knee flexion and extension. It's not purely sagittal plane. There's a little bit of frontal plane motion. Again, not in the transverse plane. That's a different motion, different axis. We're going to talk about that in a second. So as I flex the knee, I get the foot to move towards the midline. As I extend the knee, the foot is going to move slightly away from the midline. So the instant axis of rotation. This is an interesting concept in that at any point in time through the range of motion, there's an axis of rotation for that point in the motion. And it starts a little bit anterior on the femur and it moves posterior as you go through that flexion range of motion. So we can see that when I'm fully extended, my instant axis of rotation would be here and moves in a semicircular direction as I move through the flexion range. And in a normal healthy knee, if I draw a line from the instant axis of rotation to the articular surface, it should be in a right angle with a line that's tangential to the tibial plateau. So my tibial plateau runs this direction. My instant axis of rotation is in a line that is perpendicular to that line, that tangential line. So why do I care about that? That doesn't seem like it's that big a deal. The problem is, if I have a disruption, if I have a change in the instant axis of rotation, and when may I have a change in my instant axis of rotation? Well, looking at this picture, the femur is offset posterior slightly. So my instant axis is here, but my point of contact is here. So now if I take a straight line from my instant axis of rotation to that line and draw a right angle, I am no longer parallel or tangential to the tibial plateau. So what occurs then is I end up with tensile forces on the tibia anterior, compressive forces on the tibia posterior. So it changes the load, and this would be a good example of what may occur in somebody with a insufficient or a torn ACL. Is now I'm lacking that anterior tibial stability. So that's kind of an important component when we look at normal knee motion, normal knee function. Are we getting the forces to move through the joint in an adequate and appropriate and functional manner? So let's talk now about range of motion. What's normal range of motion in the hip? Well, it depends, and it will widely vary depending on a lot of factors. One factor would be the hip position. So normal knee motion is 0 to 135 degrees, Passively, you can certainly take a knee to 145, even 150 degrees. Assuming that you haven't created a situation of passive insufficiency with the rectus femoris. Now, another factor that will influence joint range of motion is muscle mass. So if I've got somebody with big hamstrings and big calves, I'm going to get tissue approximation that's going to limit my knee flexion range of motion. You know, the flip side to that is if I put a heavy load on my shoulders and do a big squat, I'm going to get an increased range of motion. So simply because it allows me to compress those soft tissue structures. So normal range is 0 to 135. If you told me it was 0 to 145, I'd say absolutely. If you said it was 0 to 150, absolutely. And you will find that kind of variance through the literature as well. Now, what is normal extension range of motion? Well, when we measure it as straight, and we measure that as 0. So 0 degrees is full extension at the tibiofemoral joint. Is it possible to be hyperextended? Normal range certainly can be as much as minus 10 degrees or 10 degrees past extension, past the full extension. If we have excessive knee hyperextension, we use a term called genu recurvatum. Genu recurvatum is excessive knee hyperextension. So occasionally you'll see individuals that stand and can lock their knees out, and it looks like their knees move posteriorly, 15, 20, 25 degrees. That's an example of genu recurvatum. So what happens during normal joint mechanics? Again, this comes back to having a good, solid understanding of our open and closed chain motions and our concave convex rule. So in the first 25 degrees of closed chain knee flexion, so first 25 degrees, the femur is primarily rolling posterior on the tibial condyles. Once I hit about 25 degrees, the ACL becomes more tight, and the anterior femoral glide is initiated to counter that roll. So the ACL becomes very important in normal joint mechanics, and the other component that really assists in that sliding effect is the meniscus. So as I get past 25 degrees, it looks like the femur wants to roll up on the periphery of the posterior aspect of the meniscus. Remember, that meniscus is shaped like a wedge, and that's essentially what it does. Is it doesn't allow the femur to roll up the hill, so it slides back down the hill. So the ACL is pulling that direction. The meniscus is aiding in that spinning effect. So when I reverse it and I go extension of the knee from flexion, that initially occurs with rolling of the femoral condyles on the tibia, which displaces the femoral condyles posteriorly. So now I'm going to roll anterior with a posterior glide of the femoral condyles. Now, after that initial rolling, the condyles glide posterior just enough that allow the roll to kind of continue. At which point the PCL takes over, and again in conjunction with the meniscus creates more of a pure spin, and that occurs up to about the last 30 degrees of from a flexed position going into an extended position. And that's when we need to start looking at how does the knee work in the transverse plane. There is a vertical axis which allows for axial rotation. And there's this concept of an automatic locking that occurs during terminal extension, which we call the screw home mechanism, and works as a function of the incongruence of the femoral condyles and the tibial condyles. So, this axial rotation and the screw home mechanism, as I have mentioned before, the lateral condyle is smaller than the medial condyle. The medial condyle is oriented slightly oblique in the sagittal plane, from the sagittal plane. So as I move towards a fully extended position, when I hit about 30 degrees, I have hit the end range of the lateral condyle. I've hit the end range. So I am no longer going to continue to move up that lateral condyle. But I haven't hit the end range on the medial condyle. I have this oblique orientation that allows the tibia to continue to roll up the medial condyle, which is going to create a lateral rotation in the tibia from about 30 degrees of flexion to full extension. And again, our ACL is providing that pivot, that tautness, to allow that external rotation to assist in the rotation. So I have ACL contributing to that motion, and I have the orientation of the medial femoral condyle contributing to that external rotation. And the important thing is that's the closed pack position of the knee, and that's where the knee is in its most stable, solid position, and allows, in fact, the quads to completely relax, completely shut off during walking when you get your center of gravity out past your knee during mid stance and as we move towards terminal stance, so that you can in fact have a quad that is electrically silent with that fully extended position, and the knee stays nice and locked and nice and stable. It makes for a much more efficient mode of ambulation, really contributing to our low cost energy cost of walking. Okay, so we're going to talk a little bit about the muscles and what muscles are responsible for creating motion and stabilizing at the knee. Well, we talked about the knee locking and the screw home mechanism, but we didn't really talk about unlocking the knee, and that's because the muscle responsible for unlocking the knee is the popliteus. And the popliteus is a deep muscle originating on the lateral surface of the lateral condyle of the femur. So when we wrap around and take a look at where it attaches, its proximal attachment's origin is on the lateral condyle, and it moves down in that nice diagonal pattern and inserts on the posterior surface of the proximal shaft of the tibia, innervated by the tibial nerve. And its primary function is to unlock the knee. It also assists in continued medial rotation of the tibia. So when I look at that flexion, we can see the popliteus functioning to internally rotate the tibia, which thereby unlocks the knee and initiates that knee flexion. So it also assists in knee flexion, and although it's not a particularly strong knee flexor. Well, let's talk about the hamstring, since we started with the popliteus, which is that flexor. Now let's talk about the big knee flexors, and the first one I want to spend a minute talking about is the lateral hamstring, or the long head of the biceps femoris. And the long head of the biceps femoris attaches at the common origin of all three hamstrings, which is the ischial tuberosity, and courses down inferior and slightly lateral to insert into the fibular head, along with the short head of the biceps, which we'll talk about here in a second. It's innervated by the tibial nerve and functions to flex, obviously to flex the knee, but also provides a rotary component for external rotation of the tibia. And proximally, we can see, as it does cross the hip joint, that there is a hip extension component and a hip rotation component, depending on where the force of the muscle is relative to the axis in various hip joint positions. If I hide the long head of the biceps and course on down here to the short head of the biceps, this is one of our smaller knee flexors, and also an external rotator, and it's probably more of an external rotator than just a knee flexor, given its orientation and size. One of the things that's a little bit different about this muscle, though, is that its innervation is the common peroneal nerve, and that common peroneal nerve is the only innervation of the hamstrings. The rest of the hamstrings are all innervated by the tibial nerve, which is a kind of an interesting, so we can look at this as a component of the biceps femoris, but the reality is it does have a different innervation, so it's probably a different muscle altogether. The semitendinosus, again originating or the proximal attachment being on the ischial tuberosity, extends down and inserts along the medial border of the tibia with the pes anserinus, as part of the pes anserinus, which is that component of the sartorius and the gracilis, where the common attachment occurs. So it's a internal tibial rotator and knee flexor and hip extensor, innervated by the tibial nerve. One of the kind of interesting things about this muscle is individuals who are having a ACL reconstruction. Their surgeons oftentimes will use the tendon from the semitendinosus, and when you hear somebody that says, "Oh yeah, I had a hamstring graft, it was my graft, well, my surgical technique," that's the tendon right there. So they'll harvest this tendon, fold it over a couple of times, and use that to replace a ruptured ACL. And lastly, the semimembranosus. And the semimembranosus attaching at that ischial tuberosity and inserting in the medial aspect of the tibial plateau. Now, innervated by the tibial nerve, and interesting, which my picture doesn't show here, is that it has a pretty expansive insertion. Actually attaches in the medial meniscus, so it's responsible for helping the medial meniscus to translate posterior during knee flexion, avoiding the impingement component that may occur. Also, it has a broad attachment into the posterior capsule, so it helps to provide stability within the arcuate complex. So it's an expansive attachment and primarily a knee flexor with a little bit of internal tibial rotation. Okay, so that's the hamstring group, and again, let's always keep in mind that the impact that it has at the knee in both the transverse plane and the frontal plane and the sagittal plane, primarily transverse and sagittal plane, and its impact at the hip where the hamstrings are hip extensors and rotators, and will assist in rotation to those glutes. So we can start to see that there's a real marriage, a real connection between the glutes and the hamstrings and their function all the way down the chain. Well, the antagonists to the hamstring group then are going to be our knee extensors, in which we typically kind of group together as our quadricep muscles. And the only two joint muscle of the quadriceps group is the rectus femoris. The rectus femoris attaches at the anterior inferior iliac spine and a groove just above the acetabulum, and we talked a little bit about its role as a hip flexor previously. And then courses down, it's a bipennate muscle. And you can see the central tendon with the orientation of the fibers obliquely. And it comes down and attaches into the superior pole of the tendon, of the patellar tendon, ultimately inserting into the tibial tuberosity via the quadriceps tendon or the patellar tendon. I typically will group the whole quadricep insertion into the tibial tuberosity via the patella, which is a sesamoid bone. It's innervated by the femoral nerve, and its function is to extend the knee and to flex the hip. If I go deep to the rectus femoris, I have the vastus intermedius, and the vastus intermedius is a deeper muscle in the anterior compartment and is located slightly below the rectus femoris, and it attaches on the upper 2/3 of the anterior and lateral surface of the femur. It inserts via the common tendon into the tibial tuberosity, and it's innervated by the femoral nerve as well. All the quadricep muscles are innervated by the femoral nerve, so that's an easy one to remember. And it functions to extend the tibia at the knee joint, and is in fact a one joint muscle like the last two muscles that we're going to look at here. The Vastus Lateralis is a large, the large quadic muscle on the lateral aspect in the anterior compartment, originating on the greater trochanter and lateral aspect of the linea aspera. So it does actually kind of wrap around a little bit, and then inserts via the patella in the tibial tuberosity. And again, it's a knee extensor. And again, look at the attachment through the patella. So we can see that we have some lateral loads on the patella that are kind of in opposition to the vastus medialis and the oblique fibers. And sometimes you'll hear the term VMO and VML for the vastus medialis longus and the vastus medialis obliquus. And there's some controversy in looking at, does the oblique fibers actually pull the patella medially? It depends on what you read, and I think oftentimes we look at that VMO as a component to patellofemoral dysfunction, and there may be some contributions. There may be more contributions from the hip rotators and the relationship that creates between the femur and the patella. But the vastus medialis originates on the intertrochanteric line in the medial lip of the linea aspera, and inserts via that patellar tendon in the tibial tuberosity, and is again innervated by the femoral nerve. And its primary function is extension of the knee at the knee joint.